Hello, good morning. I'm Renee Schellhaus. I'm a pediatric epileptologist at Washington University in St. Louis. I talk in front of a lot of audiences, but I think this might be my favorite one ever. It is so great to see all of you and your kids and to hear them. I have brought each of my children to conferences over the years, and I've gotten a lot of side-eyed looks when they made a little squeal, but I love hearing the sound. So thank you for being here and being here together. And thank you to our parents for sharing their stories. This is a hard act for me to follow. Who am I to tell you where LGS care is strong and where the gaps are? You know this already. But Tracy asked me to do it, so I'm gonna do anything that Tracy says. The answer is yes, so I'm gonna do my very best, all right? I also adopted a growth mindset in putting my slides together and said, I can work with AI to make pretty pictures. So if you like the pictures, I worked hard on them. If you don't like them, it's Gemini. So the glass is half full and the glass is half empty, right? We know this, and we're gonna talk through just a few things. We obviously can't, in a short period of time, go through everything that's good and everything that's bad about LGS care, but I'm gonna highlight just a few things in each category. I like to be an optimist, so I'm gonna start with the glass being half full. We're gonna talk about EEG, genetics, new medicines. You've already heard all of this today. I'm just gonna reinforce, okay? So EEG, we talked about what an LGS EEG looks like. What does a normal EEG look like? How many of you have seen a normal EEG ever? Yeah, just a few who, Dr. Perry didn't raise his hand, I don't know. It's not his job. Once in a while, I get to see a normal EEG. Here's what a normal EEG looks like. What we have here is each of the little thin vertical lines is 1 second of time, okay? And bottom line is it's organized differently from the front to the back, and the left and the right should basically look the same, okay? So what we have in that little red bracket is something we call a posterior dominant rhythm, which you should see in a normal EEG, and it doesn't look like a kid with LGS, right? LGS has an EEG signature. It's the slow spike and wave. You already saw it from Dr. Perry, but you see how that looks quite different from the previous study, right? Again, those vertical lines are 1 second. You see these slow waves. And this is a person who's probably just doing their thing. This isn't a seizure, but it kind of looks like a seizure, and it can scare an epilepsy doctor when they see this EEG for the first time. LGS also has this other signature called generalized paroxysmal fast activity. So we get in the middle there, can you see how it kind of gets fuzzier and darker and lower in amplitude? That's generalized paroxysmal fast activity. That can be for a person with LGS, not a seizure, but it kind of reminds us of a seizure. And so on the left here, we have not a seizure, generalized paroxysmal fast activity. On the right, we have a tonic seizure, which they look pretty similar, just extends out a little bit. Why does this matter? Because when we see these patterns as an epilepsy doctor, we can name them, and when we name them, then we can start to put the syndrome together, we can start to put together what the treatment might be, and talk to you about all of the planning and work that we need to do together. So, do we have the right diagnosis? Are all the events of concern seizures? I think this is really important as we think about the capability of doing a little bit longer EEG. Can we capture an event and decide, is it a seizure or not? If it's not a seizure, no amount of medicine is going to make it go away. Are we recognizing all of the seizures, or is the child having seizures that we can't tell? Or are we recognizing the different kinds of seizures that a child is having, or an adult? And how does the in-between seizure EEG, the interictal EEG, impact that person with LGS? So, we can get a lot of information about the EEG. One of the things that I think about for somebody who I anticipate the in-between seizure EEG is going to be abnormal is to have a baseline EEG when they're doing well, so that I know what their EEG looks like when they're doing well. That way when they come into the hospital when they're not doing well, I can compare. Because I expect they're not going to be a stark normal EEG, then I won't be as nervous in the middle of the night trying to figure out what to do. So that can be helpful. Then we talk about genetics. Genetics are a real game changer. There are hundreds of identified genes that can be associated with epilepsy and certainly associated with LGS, right? And we're getting better at being able to offer genetic testing in routine clinical practice. What that does is if we can identify a gene, then we can say, we have some maybe therapeutic guidelines some practices that we can do, and we can potentially tailor our therapy. We can connect people with communities around that gene and think about what our better care might look like. The reality, of course, Gemini makes it look very pretty and simple, is we have a really long way to go. Each of the colored figures on that left-hand figure represents a gene that we've seen that's associated with LGS. It's going to be a long time before we have a genetic treatment specific to each of those genes, right? And we know that there are plenty of people with LGS who don't have a genetic reason for their epilepsy. But we still need to look, right? Having a specific diagnosis when we can get one makes a big difference. How does it make a big difference? Well, I don't need to tell you this. If you understand the reason, that really can help with sort of that diagnostic odyssey. It can help us with thinking about what could be precision medicines. What can we avoid that might be a bad choice of medicine for my child? Can we get rid of some of the trial and error of prescribing? Can we get a definitive answer that helps us to connect with family groups, make peer support and communities possible, enroll in clinical research, whether it's a registry or a trial, and get ourselves towards pipeline therapies. And think about how that genetic diagnosis have an impact on siblings or other children we may have. All right, this is what happens when you say, Gemini, give me a list of, or a picture of medicines for LGS. It gives you this, take it or leave it. Let's talk about medicines. The good news is that we have a number of medicines that have a specific indication for LGS. So that means if you have the LGS diagnosis, it's going to be easier to fight with the insurance company to get coverage for that medicine. Okay, and we have some idea that they might work. Here's the other good news, though, is there are a lot of anti-seizure medicines, and we can have access to most of them, right? So to me, that's a glass half full, right? And we're learning more and more medicines. Also, the medicines work in different ways. So this is just to give you a picture that each of those squares, or rectangles, I guess they are, names a medicine that works in a different way in neurons, okay? And so if we're giving, as an epilepsy doctor, if I say, look, I'm giving a lot of medicines that work on the GABA aspect of the way that a neuron works, and I'm not getting where I need to be, maybe I need to pick a different one. Maybe it's the sodium channels I need. Maybe it's the AMPA receptors I need. I need to think differently about the medicines. All right, but the glass is not always half full. Sometimes it's half empty, and I think a big piece of the half empty is access to care. Do we know what care we need? Who we need on our team? Can I get the referral to the person, right? I didn't know I needed a special referral to adult pulmonology. How long is the wait once I get that referral? Will they take my insurance, especially as we transition from pediatric to adult care? How far away are they? Can I get there? Do I have transportation? Is it the right priority? I've got a lot to do. Can I fit it in our schedule? And in the whatever happens on the day-to-day, right? So access to care obviously is a huge issue, and there are a lot of needs, and I don't need to read the list to you, right? But there are a lot of doctors involved in taking care of a person with LGS. We have our clinical support team, right? All the therapies. And don't forget school and insurance and wraparound service and legal services and so on and so forth. Each of those has its own access challenges. Glass half empty, right? And we have our non-seizure issues or comorbidities, right? And those are going to change over time. When we're little, let's look at development, cognition, language, motor, behavior. Are we screening for autism traits because we know we have therapies we might want to intervene soon? Sleep, quality of life. How are our parents doing? They get a little bit bigger. Maybe we're looking at executive function, sort of how can they control their behaviors if possible, right? Social interactions. Again, sleep, motor function, quality of life, and parents. When they get into closer to the teenage years, adding transition readiness needs to be on the list that we're all thinking about. And there's sort of the Wild West of adult care with LGS that we really need to learn a lot more about, right? But what is the long-term care plan going to be? In an ideal world, right, we have this lifelong journey where everything is organized and coordinated and as easy as it can be, where we have early coordinated pediatric care, supported education system, we transition well, we have legal planning, we have adult care, we don't forget our primary care as well, and the support around that person and vocational and social inclusion. How many of you have that? Right. We don't live in the ideal world, right? But that doesn't mean we throw up our hands and we give up, right? We keep working to fit the pieces together, figure out what our priorities are, build our own as inclusive way as we possibly can, and we never lose hope. And my patients know I never give up. The good news is that there are a lot of people working on these issues, okay? So here's just one example of the Beyond the Seizure initiative, where they're talking about integrating seizure control along with cognition, behavior, sleep, quality of life, lifespan-oriented care models, transition services, and so on and so forth. So we're not alone in this, okay? We're also glass half full here with LGS Foundation, right? And I just grabbed this from the website, but 12,000 plus community members, tons of researchers, a pretty robust research funding portfolio that's gonna get bigger after this weekend, and people who are enrolled in the every patient database, right? So glass half full, we are making progress. All right, so I took you on a little whirlwind. Here are some of the things that I view as big challenges, some of the things that I view as potentially we can be optimistic about. But really, I think us being here together it's certainly filling my cup, and I hope that we can work together to fill the cup even more. So with that, I'm gonna turn it over to my dear colleague.